Hey, future nurses! Welcome to our explainer on a topic you are absolutely going to see on your NCLEX, peripheral venous disease. I know it's a huge subject, but we're going to break it down into the must-know, high-yield facts to help you crush your exam. So, let's dive right in. Right off the bat, I want you to see this statistic, because it really sets the stage for why this is so important. Venous thromboembolism, or VTE, is the #1 cause of preventable death in hospitalized patients. That's huge. This isn't just about passing a test, this is about saving lives.
So here's our game plan for today. We're going to start with the VTE threat itself. Then we'll get into the why behind it with Virchow's Triad. You gotta know that one. From there, we'll jump into your role as a nurse, what to look for, what to do about it, and finally, what you need to teach your patients. Think of it as your roadmap to mastering this for the NCLEX.
All right, let's kick things off by really defining the problem and understanding just how serious the VTE threat is. The whole VTE story usually begins with a deep vein thrombosis, a DVT. It's exactly what it sounds like, a blood clot that pops up in a deep vein. And 9 times out of 10, we're talking about the legs. While it can happen elsewhere, the NCLEX is definitely going to focus on the lower extremities.
Now, a DVT in the leg is bad enough, but here's where it gets truly terrifying. A piece of that clot can just break off, travel right up through the bloodstream, and lodge itself in the lungs. That causes a pulmonary embolism, or a PE, and that can be fatal. This is the absolute worst-case scenario we are always working to prevent.
And please don't think this is some rare thing. VTE is incredibly common. We're talking up to 600,000 people a year in the US alone. And look at that number of deaths, at least 100,000. That's more than AIDS, breast cancer, and car accidents combined. The cost is astronomical. But it's really the human cost that shows why your role in prevention is so critical. Okay, so we get it. VTE is a huge threat. But why does it happen? If you want to prevent something, you have to know what causes it. And for the NCLEX, the answer you need to know is Virchow's Triad. Seriously, burn this concept into your brain for any question about VTE risk.
Virchow's Triad is just a simple way to remember the 3 main things that put a patient at risk. Just picture your classic post-op patient. Let's say he's 70 and just had knee surgery. Well, the surgery itself causes that endothelial damage. He's on bed rest, right? That's venous stasis, and he's probably a little dehydrated after surgery, which leads to hypercoagulation. Boom! That patient is a textbook example of Virchow's Triad, and his risk is through the roof.
Okay, we know the why, so let's shift gears to the what. As the nurse, you're the detective at the bedside. You're the one who needs to spot the early signs of a DVT.
The classic DVT signs are almost always unilateral. That means they're just on one side. That's a huge clue. You're looking for swelling in one leg, and here's a pro tip for your exam and for real life. Measure the calf. If there's a difference of more than 3 centimeters, that is a massive red flag. You'll also feel for warmth, ask about pain or tenderness, and look for any redness.
Okay, everybody, lean in for this slide. This is a game changer because this is a classic NCLEX trap. Confusing venous and arterial problems. I totally remember a question on my exam that almost got me because I wasn't solid on this. This table breaks down all the key differences. Know it, love it, memorize it. It will save you points on the test, I promise.
So we know what to look for. Now let's talk about what we're going to do. This is all about your priority actions as a nurse. Prevention is everything with VTE, and it really comes down to these 4 things. 1. Get your patients moving. Ambulation is the enemy of venous stasis. 2. Push those fluids. Hydration fights hypercoagulability. 3. Use those compression devices and make sure they fit right. And 4. Give those anticoagulants, as ordered, to stop clots before they even start.
Here's an intervention that's so simple but so effective. I've seen it work wonders. For a patient who already has a DVT, you want to elevate that leg. You're literally using gravity to help reduce that swelling and get the blood flowing back to the heart. It's a small thing that makes a big difference.
So a question you might get is how long a patient needs to be on anticoagulants. For a PE or a significant DVT, the standard of care is at least 3 months. That's a really key piece of info, especially for your discharge teaching. When your patient's in pain, your go-to is going to be warm, moist heat. And for meds, acetaminophen is your safest bet. Now, what's just as important is what not to do. You never ever want to give NSAIDs, like ibuprofen, to a patient on anticoagulants. It just shoots their risk of bleeding way up. This is a critical safety point.
All right, let's wrap this up with one of the most important things we do as nurses, patient education. We have to empower our patients to keep themselves safe after they leave the hospital.
This right here, this is a life or death piece of teaching for every single patient with a DVT. You have to tell them and their families to never ever rub or massage that leg. It might feel good for a second, but you could literally break that clot loose and send it straight to their lungs. It is a non-negotiable rule.
Your discharge teaching is all about lifestyle changes that help with blood flow. So you're going to tell them no tight clothes, no crossing their legs, and no sitting for hours on end without moving. And of course, you'll hit the big ones. Maintain a healthy weight, stay hydrated, and if they smoke, it's time to quit. And make sure they know how to use their compression stockings correctly.
This is probably the #1 warning for any patient going home on blood thinners. I always spend extra time on this. They have to know to call immediately if they see weird bruising, get a nosebleed that won't stop, or see any blood in their stool or urine. Those are major red flags that need medical attention right away.
Okay, let's finish up with a classic NCLEX-style challenge to get your critical thinking gears turning. Picture it. You have a post-op patient, super high risk for a VT. They don't want to get out of bed, and they're refusing to wear their compression device. What is your priority? What's your very first move? This isn't just a test question. This is a real scenario you will absolutely face. So take a second. What would you do?